So in the beginning, I'll actually be rehashing a little bit from what you heard from Professor Delaporte. And I think the importance is there's really no question that ultimately novel therapy is what we need for these patients. And so how we classify these patients in order to get them on clinical trial is going to matter a lot. I think, unfortunately, we've had a lot of impediments on arbitrary blast thresholds that have actually slowed development, but I think we're all actively working towards this. So again, this just summarizes WHO and ICC as far as recognizing that P53 biallelic or multi-hit disease exists. WHO does sort of significantly undercall. I think the biggest discordance, and there's several publications, is complex karyotype is not viewed sort of as a multi-hit equivalent. This is recognized by ICC. Again, with WHO is only in the setting of MDS, so sort of no call out in the setting of blast greater than 20. Again, ICC, there is a VAF cutoff, and there can be some difficulties, whether or not it's peripheral blood, bone marrow, et cetera, from this perspective. But again, the mutation requires a VAF of at least 10% or greater. I think both of these we can further improve and harmonize, and I'll show some efforts on that in a moment. Again, these were data a long time ago as sort of the first 5-gene signature by Raf Bahar and colleagues, had reported that, of course, P53 mutation predicts for inferior overall survival. But again, if you just look at the clonal burden of these patients with variant allele frequencies, long-term survivors were very rare in patients with an allele burden greater than 40%, whereas in patients that had this VAF less than 20, and you're going to keep seeing this number throughout several subsequent slides, was really predicting for far improved outcomes, including validation from the King's College. Of course, this work was advanced where we have the presence of multi-hit and a very large international collaboration to predict for inferior overall survival versus patients with single hit. I would argue that this cohort was somewhat enriched in lower risk patients from that perspective and may differ a little bit from some of the other papers that have been out there. But I think what's relevant is if you look again in the supplement of this paper, as soon as the allele frequency is greater than 23%, again, these patients relatively had uniformly poor outcomes. And part of the reason to discuss this is, again, very sophisticated single-hit, multi-hit calling is definitely not available and is actually still being advanced as we speak. So can you go with probably biallelic? This is work from the Cleveland Clinic group, whereas essentially, again, a VAF greater than 23% predicted for essentially a probable biallelic setting, again, with poor outcomes. So what about the clinical setting of this disease? I think you heard nicely that in the Delaporte recent model that, again, blasts do not matter as far as predicting of outcomes. Again, this has been shown by several groups. Again, actually first in the bottom left. And then a very seminal work from the Hovan group. You could see AML is in red, so this is 20% blasts. And MDS is orange, this is 5% blasts. As soon as blasts are 5% or greater, there's essentially completely superimposable outcomes. And so why is this? Again, very eloquent work through several publications from the MLL group. Again, as soon as the patients do have 5% blast or greater, the vast majority of these patients, you can see actually up to 90% in patients with 10 to 20% blast, have essentially a multi-hit state. And it's really in the patients without an increased blast where it's really the reverse, where you can have a majority of patients that are single hit. So can we harmonize this? Again, this is really nice recent paper. This is a collaboration from both the Mayo Group and multiple centers in Australia, and I think it's quite simplistic and relatively easy to use. If your blast count is 5% or greater, you had a median overall survival of 8 months or less, and really all the sophisticated testing came down to impacting the lower blast group. So if patients had biallelic inactivation or complex karyotype, you had a median overall survival of around 1 year. Sometimes people argue what's the difference between the terms terrible and horrible from that perspective. But it was really only the patients with low blast without any of these features that had a very good median overall survival of 35 months. I think what's relevant, and I would say our data look exactly the same at our center, is when we look at the patients in our group, around 90% of patients are this adverse risk group. So I do think it's very critical of identifying the small subset, but maybe at times we talk too much about this, again, with unfortunately the majority of patients being this ultra high risk group. So can we harmonize these classifications? Again, this just summarizes WHO and ICC. Again, we need to remove this MDS versus AML calling, and so sort of a harmonized definition is just myeloid neoplasm with biallelic or multi-hit P53. I think ideally we do have the most sophisticated analysis. We should be able to see 2 or more P53 mutations in trans or single P53 mutation in the setting of alterations of chromosome 17 or copy-neutral loss of heterozygosity. Again, there will be probably biallelic states, again, mostly in the setting of complex karyotype. Again, this is what I think would be optimal. At the same time, there could be a more easy sort of favorable versus unfavorable separation where, again, we look at blast, we look at the presence or absence of complex karyotype. Again, in cases, without this, potentially lower allele frequency may be best to help stratify these patients. Again, with the critical nature that we need to have relatively uniform cohorts going into prospective trials, which I'll show in a moment. So I think at the same time, I do think sequential analysis of these patients really tells you a lot. Really, the serial VAF of these patients ties into the clinical trajectory of these patients. So this just looks at it a couple of different ways. So if a patient expands their clone at any time to greater than 20%, these patients have inferior outcomes. Whereas if patients achieved NGS clearance, this is not by deep MRD, this is with a VAF cutoff between 2 and 5%, patients have improved outcomes. And I think when we get to the next talk of really thinking about novel therapy, again, potentially this may be a better early metric than just CR, composite CR, as far as looking at molecular clearance in the setting of response. Can that help us choose the right therapies to be excited about earlier? So a big question, again, once they get to multi-hit, these patients unfortunately do very, very poor. I'm going to show a lot of data with very poor overall survival. And so potentially the possibility is, do we need to intervene early? I think one of the challenges is how the clone behaves is very much dependent on the selective pressures. So if a patient, for example, has no selective pressure, maybe we need to leave that patient alone. Whereas in patients, again, in the wrong microenvironment and maybe have a very, very ultra high risk to get to multi-hit disease, at which point their outcomes are relatively uniformly poor. And again, I think highlighted by Delaporte, and I'll show a little bit later, again, transplanting single-hit patients likely has a very high cure rate. And again, thinking about this to intervene or to not intervene is a critical question. I think what further supports this, again, this is the CHRS risk score for essentially, for patients with CCUS, but this is from a healthy volunteer study. Again, this is without necessarily a selective pressure. And although P53 is included in their score, again, if you look at the hazard ratio of ultimately developing disease, it's essentially null from that perspective. So I think we need to have large international collaborations in order to prospectively, sequentially analyze these patients. To answer the question in the session is, again, what is that sort of time at which point they may become multi-hit, at which point, again, their chances of cure become much, much lower. Again, in these ultra high-risk groups, particularly post-cellular therapy, these patients are very, very high risk to ultimately developing multi-hit disease. And again, do we need to think about early stem cell transplant? And maybe as we look into sort of novel immune microenvironment studies, again, there's an oral presentation in MDS here at this Congress looking at sort of this NEX7 inhibitor or Finnerflas, and there was a P53 patient that actually cleared their clone and had very long-term durable response. And so potentially, although immune microenvironment novel therapies has somewhat been underwhelming in P53, again, potentially earlier utilize of these therapies may be optimal. So how do I think about the approach? Again, basically uniformly calling this multi-hit or high-risk group, and no question, options 1, 2, and 3 need to be clinical trial. Outside of a clinical trial, at least right now, we're dictating more on whether or not the patient is a potential candidate for stem cell transplant. Whereas if patients are not, we are utilizing HMA therapy alone, with potentially slight preference for oral decitabine. There's some recent data, including out of the MD Anderson group, with propensity matching, that maybe there's a slight numerical advantage. I personally think there's not significant differences between type of HMA, but our preference is there in some cases. Whereas if they're going for transplant to get more rapid blast clearance, we are still incorporating venetoclax, given, of course, this has not improved the standard of care. And again, throughout through their clinical management, at any point we're trying to transition them to stem cell transplant. We do optimally like to get cytogenetic and molecular clearances, and I'll show some pro and con data on there, as well as thinking about novel strategies in the post-transplant that I'll highlight at the very end. So this kind of summarizes what we have. If you look at all AML trials with P53, you essentially have a median overall survival of around 6 months. If you look across MDS, you're anywhere between 6 and 12 months, and some of this may be based on single-hit patients being included. Essentially, with HMA or HMA venetoclax, you have true complete remission rates of around 20%. And even with extended 10-day decitabine plus or minus venetoclax, we have still, unfortunately, not improved overall survival. There is a rare group of subpatients that may purely have CHIP and subclones, and those patients may be treated differently, even potentially with intensive chemotherapy at times, but again, that's a very small subset. So these are data I'll be in press momentarily. These are from the phase 3 trial ENHANCE. Again, I'm not going to go in detail about magrolimab in this presentation, but the question is, what are the outcomes for P53 mutant patients and prospective trials? Okay, and so the median overall survival, you can see in the placebo-aza arm was 11.5 months. It was actually 10 months in the magro-aza combination. Of course, not what we were necessarily looking for. Again, so this is really what our standard outcomes. I think a null hypothesis of around 9 to 10 months in P53 mutant patients, especially if they're more enriched for multi-hit, makes sense. I think one challenge is we keep running trials without controlling for this, and there can be an imbalance. You can see there's 41% of patients in the combination versus 34% of mutant patients in the placebo. Again, we can run pivotal phase 3 trials specifically for this group, but at a bare minimum in studies, we have to stratify and not, control for pseudo things such as complex karyotype. So similarly, again, there was phase 3 trial ENHANCE-2. This has been published a couple years ago now in blood. Again, 101 patients in the magro-aza, 104 in the ven-aza arm. And this is just to highlight one of two features. One, median survival with standard of care therapy in P53 AML is 6 months. And second is we don't have any good standard of care therapy. Again, FDA was completely on board, with the fact that you can choose your conventional therapy. Independent of age or fitness, you could go on ven-aza or 7+3 chemotherapy in this trial, and again, the outcomes were uniformly poor. Again, this is the bar that we have to beat. So I'll talk just very briefly about epranepopt or APR-246, and I'll give some rationale why in a moment. Again, this is a prodrug that is spontaneously converted to MQ. It does have P53-dependent mechanism of action to restore wild-type conformation and induce cell cycle arrest, but clearly has other mechanisms such as ferroptosis, where there may be a preferential sensitivity in P53 mutant patients. Now, there were 2 parallel phase 2 trials, one led by the US and another by the GFM by Thomas Clouzot, and we put these data together. Again, this rehashes somewhat what our response rate, and again, 90% of these patients were multi-hit, speaking for who's coming in, but there's still a slight dilution factor as far as single-hit patients. I think what was most interesting in this study is when we look at the quality of response, this very much dictated their long-term outcomes. So patients that achieved complete remission, particularly complete remission with P53 clearance, which is the green curve, had a median overall survival that was substantially better versus patients that were transplanted without molecular clearance in the setting had outcomes no different than patients that were not transplanted. So, of course, a phase 3 international study was run. Again, we can do these trials through international collaboration. It's a relatively small study at 154 patients during the COVID time. It was also an open label trial, so there was not a placebo control, which I think was a negative. And we're still now, I think 6 years later, stuck with a singular press release and a p-value of 0.13. Now, these data, again, one main mission is to get them out, because when this trial was built, this was pre a lot of the sort of multi-hit discussion. And the question is, would this trial have been positive if it had focused on multi-hit mutation? How does it work if there are other driver mutations? Again, we're going to work to have this out. And again, can we resurrect epranepopt is actually a real mission that we hope to in this maybe coming year or so. So really in the last part, we'll focus on transplant. Again, this is one of the biggest and most contentious factors as far as standard of care therapy, for our patients. Many centers potentially not transplanting these patients. One issue and challenge in the US based on non-relapse mortality that may be heightened in these patients is, again, many centers being afraid of these patients and increasingly not offering them a curative therapy, right? This is the only thing that can offer long-term survival. Even in patients that are not ultimately cured, survival survival is often substantially better. Now, again, of course, there are challenges. These are the two large, cohorts with the CIBMTR, MDS data, on the left, and the EBMT data on the right. I think what is relevant is independent of age and fitness in conditioning intensity, there's really no impact on outcomes. We have this essentially 20% curve. I think what's nice from the EBMT paper is, again, particularly patients without complex karyotype, which is likely enriched in patients with single hit, had far better outcomes. So again, considering early intervention and transplant prior to multi-hit acquisition may be one key step to improve overall survival. Now, again, molecular clearance we still think is impactful. So a while back, we looked at all patients at our center who are essentially treated with HMA-based monotherapy. And unfortunately, if patients did not have molecular clearance, we can see very rare long-term survival, whereas we had a hazard ratio of 0.28 in patients that achieved P53 clearance. Now, I don't think this should preclude patients from going from transplant, but a number of patients are very borderline from, let's say, comorbidity scores, et cetera. And I do think it can be useful in those settings where, again, is the benefit likely going to be there or not? Now, I think in contrast to that, of these data, and this was a follow-up publication, from the data that Professor Della Porta showed, is looking at P53. So again, no question that survival is improved as a time-dependent covariate. But I think what they did is they did nicely look at a small subset, 35 patients, and unfortunately in that data, there was no improvement of outcomes in patients that achieved clearance. Now, I think the subset may be a little bit unique. If you look at the patients that achieved clearance pre-transplant, they were all relatively low VAF. And again, it was a little bit before sort of the multi-hit, single-hit calling. So it's still a response that I try to achieve. But again, this at least supports that it shouldn't be a 100% exclusion in that setting. Now, what about novel MRD in the setting of P53? I think getting these patients to transplant, thinking of both pre, peri, and post-transplant strategies is really critical, but MRD is very insightful in this group of patients. One scary feature is about 80 to 90% of patients have a detectable clone, at least on their day plus 30 bone marrow when you sequence deep. And so this study was done in the setting of our eprinetapop-aza maintenance trial, but again, I think highlights a number of unique features. So again, because nearly all patients are positive, thinking about post-transplant maintenance, I think, is highly relevant. When we looked at our patients that either did not relapse or had very long-term outcomes, essentially all of these patients achieved very deep MRD. You can actually see the only patient that relapsed had a detectable clone, technically MRD negative as our cutoff, at least for this project, was at 0.01%, but clearly was detectable with the same pre-transplant clone. This trial mandated patients to come off of maintenance at 12 months. So what would have happened, for example, if we had extended maintenance? The two other patients that relapsed had very late relapses at 32 and 30 months respectively, and one of these patients was a P53 wild-type extramedullary relapse at the time of that. So again, achievement of this was very impactful for predicting outcomes. On the flip side, if patients had sort of a detectable MRD or growing clone at any time, you can see essentially there's uniform relapse in these patients. The one exception, again, is the patient 001030 on the bottom, where again, you can see had this detectable clone. This patient was rapidly tapered off immune suppression along, with DLI and extended maintenance, and this patient did not have relapse. Again, a little bit in contrast to the patient on the earlier slide, again, helping dictate what to do with these patients. And again, when we looked in general at patients that had durable MRD negative, again, this trial ended essentially at cycle 12, where we had our last sample, had substantially improved outcomes, particularly in regards to relapse-free survival. So there are other ways to potentially look at MRD. Of course, cost is a key consideration. So this is really eloquent work by Stephen Chung at UT Southwestern that we've been a collaborating center for, mostly from a sample perspective. And essentially, it's relatively simplistic. He sorts out CD34 cells and essentially does selected deep sequencing in HSC, LSC populations versus LMPP and other progenitor populations. And again, this was not a project necessarily specific for P53 mutation, but again, in bulk, as you could see, like this, patients were largely negative, whereas in patients that had presence of a mutation, he's getting ultimately up to near 100% certainty on ultimately predicting relapse. I think there's a singular patient that did not relapse, which is a patient of mine that maybe does not have long enough follow-ups, for him to ultimately get up to 100. But again, very, very great separation. You can see 4.7 times 10 to the negative 9 is actually, this is a relatively inexpensive assay. But just to give a specific case to P53, again, this was a patient that was a multi-hit patient that had a dominant clone of E286K. You could see at the day plus 100 bone marrow, the patient was bulk bone marrow negative, but clearly had the same detectable clone in stem cells. So again, could we have done something in this group? You could see relatively rapidly within 6 months of this time point had full rapid relapse and essentially 100% of cells ultimately having this mutation. So I do think, again, we need to improve outcomes to stem cell transplant, but incorporating novel MRD in that setting will be pivotal. So what about maintenance? Again, because we know that almost all patients have some level of detectable clone, buying time for the GVL effect, particularly in many of these patients having reduced intensity transplant, is key. Again, targeting the clone, again, with novel therapy will be relevant. So for a while, we've been incorporating relatively standard HMA maintenance off protocol. Really for this was all parenteral, although we've transitioned to oral, and hopefully we'll have some maybe data at meeting this upcoming year. But when we looked at patients and we data cut to have at least 2 years follow-up when we presented these data at ASH of this last year, median overall survival was over tripled in patients that had maintenance versus patients that were without maintenance with a better sort of long-term tail of the curve. And again, we tried to correct for everything. So this was independent of multi-hit status, P53 allele frequency, complex karyotype, blast cutoff, donor intensity. We're still doing some additional subset analyses. And again, this was also positive when we looked at patients based on a 3-month landmark. And so we'd love to prospectively run a HMA maintenance focused trial on P53 and have at least submitted a concept. Again, we would look for international sort of collaboration in that setting. But off protocol, given how poorly these patients, again, I think it is very reasonable to consider initiation of maintenance. Some of these patients require sort of more dose adjustments and titration, but we have patients now years on maintenance. I think a separate question is for how long. I think we're sort of ultra scared in this group of patients, whether or not 2 years is adequate enough. My hope is sort of with novel MRD that we can guide that approach, similar to what's been done with other molecularly targeted therapies, for example, in the FLT3 space, but this is something we're doing relatively universal at this time. And I think a lot is, again, sometimes running these trials is very difficult. Sometimes pharma is also concerned about these groups. And so, real world prospective international collaborations are needed. So I think this is a really amazing initiative I want to highlight. This is led by Millie Shaw and Charlie Craddock and others in the UK, but Millie's really put an amazing amount of work. This is called the TP53-DLI International Initiative. It is active in UK and is going to be opening at our center, some other centers across Australia and Canada. And essentially, what the goal of this trial is, one is we're prospectively collecting samples, both pre and at all standard stem cell transplant assessments. These patients are essentially can have physician's choice whether or not they get RIC, MAC, and we had to play nice with different transplant approaches across the pond from that perspective. But patients are rapidly tapered off immune suppression. So the goal is to have them off by between day 80 and day 90, and then the patients to get prophylactic DLI, potentially at an ascending dose, given somewhere between day 20 and day 150. Now, will this be enough? I think the question is out there, but our hope is, can we move the tail of the curve from 20% to 40%? I think this will really be an amazing initiative, and look forward to hopefully having data for this maybe in the next year or two. Again, it requires international collaboration. And with that, happy to take any questions. Thank you for listening, and this is Moffitt Sky every day. Thank you.
Everyday sun and water. David, thank you for this excellent overview on the current strategies. The floor is open for questions. Who may start? So maybe I can start. when you started, you reviewed the data about the data also Matteo in some extent presented. So I was a little bit confused. Matteo showed quite clear that the TP53 status doesn't matter independent on blast percentage or FAF. And you showed some difference. What is actually now the next step for defining the real TP53 status? So there seems to be some issues not fully aligned, so that makes sense because therefore you make clinical decisions.
Yeah, I think there have been some challenges in the fact is how the sort of technology and assays behind multi-hit calling have kind of evolved and have differed between some of the studies. I think where the data are very, very clear is if you do not have multi-hit disease and you have all the clinical low-risk features, again, patients without complex karyotype, without increased blast, that is the biological and clinical group that does very, very differently. I think how advanced we need to be in calling, I think you'll get differing opinions. Some say we 100% need to assess definitively whether or not we have multi-hit or not. Again, I think some of this can be a very reasonable surrogate. But I would pitch, again, for our future trials that we run a trial, P53 mutation with any of these features, biallelic, multi-hit, 5% blast, complex karyotype. That is good enough, I think, to define our population, at least for right now in prospective studies.
Clear. And microphone in the middle, 4.
Thanks. Hey, David, James Foreign, Mayo Clinic. Thank you for that presentation. I had not heard of the DLI initiative before. Can you comment a little bit on the rationale? Is that to select patients who can come off immunosuppression early and sort of the background data to support augmented T cells for them?
Yeah, I mean, I think the rationale, I mean, clearly, you know, P53 mutant patients are the most resistant to the GVL effect of transplant. And again, I would love to have the sort of novel CAR T therapy that we could maybe introduce, you know, immediately post-allo. But I think until that time point, I think we try to do anything possible. We actually know, and Della Porta showed some, we have an older paper as well, there's really a profound immune dysfunction in this group. And there's likely at the stem cell level, we know that there's PD-L1 upregulation as well. So anything that we can do to sort of augment GVL is essentially the relatively simplistic scope of the study, just to see can we move the bar and get a better tail of the curve essentially for long-term survival. I think what's nice in that trial is, again, because of the sequential, you know, prospective collection, we'll be able to answer a number of other questions as well.
Yes, in the front, please.
Thank you for the talk. Hassan Sibai from Toronto. So basically, in your algorithm, chemotherapy not exist anymore on patient have more than 10% blast, if you call them AML. Would you use chemotherapy at any point for those patients? If they fail 2 cycles of aza-ven, like,
so I think
what type of chemo would you use? Would you keep the venetoclax? Thank you.
Yeah, I think to your great point, right? We all still have the patient in front of us that's failed, let's say, prospective HMA venetoclax, and let's say we don't have a clinical trial. And so I think in all those settings, and it's in the sort of algorithm, is, you know, consider, you know, high-dose chemotherapy. I think particularly in this group of patients, you have one shot. These are not a patient group that you can give multiple rounds of intensive chemo. So in general, you know, we've been more, you know, either, you know, either CLAG-M, which is ours, but I don't have a big difference between, let's say, you know, CLIA, FLAG-IDA, et cetera. We often will use a more high-dose cytarabine one strategy. I have had some patients that I think clearly cannot tolerate that, and cladribine, low-dose cytarabine, venetoclax, we have had even some remissions in P53 mutant, have been able to bridge some patients to transplant. I think the challenge, if, you know, it's a really in-depth conversation with the patient, and if really the goal is transplant, your window is tiny. I mean, it's often 1 to 2 months best case scenario in the setting of giving that sort of salvage chemotherapy. And so, you know, working with your transplant group, truly being ready to transplant, sometimes in the most not optimal clinical scenario is key, or else you went through this whole feature without any benefit. I think if transplant is not an option, clearly I would not do that. Although, again, I think cladribine, low-dose cytarabine, venetoclax is tolerable enough that it's not a great option, but can be a consideration.
Final question on the right of my hand.
According to the data you show, is there any group that it is not worth to indicate the bone marrow transplant?
No, I think we should offer transplant for every patient that is fit enough for it. I think the challenge becomes, again, the patient that's sitting in front of you. There are many patients that are very borderline from that perspective. So in our practice, if they're more borderline, we are really looking for that more optimal response before considering. But I think if you have that fit patient, that there is no functional, that all these patients should be offered, ideally, again, with novel therapy before, novel therapy during, and then maybe some of these initiatives, thinking about off-label HMA maintenance as well.
David, thank you for this nice overview and all the new details. Thank you,
Thank you.
for this excellent talk.